Brenner, Federal Programs Unit.
Okay, thank you. Thank you for joining us today to talk about an exciting topic of home and community-based waivers. So we do the slides here. They walk through what exactly a Medicaid waiver is. Details of Medicaid waivers, there's a few terms that we want to go through, so that way you can kind of keep up as we go along. Center for Care and Medicaid Services, this is a federal government agency under Health and Human Services that provides health care coverage through Medicare, Medicaid, and Children's Health Insurance Program. This is basically the federal agency that provides approximately 60% of match to our Medicaid services, so that match is the funding. All of our services are federally funded. They must be reviewed and approved by CMS, Center for Medicare and Medicaid Services. So waivers and services, this department, this agency is the one to review and approve those. Intermediate care facilities for individuals with intellectual disability, those are also known as ICFID. These are Medicaid benefits that enable states to provide comprehensive and individualized health care and rehabilitation services to individuals to promote their functional status and independence. They're only available to individuals in need of and receiving active treatment. This is basically our divisions, the Division of Developmental Disabilities, institutional facility settings. And we, again, refer to these as ICFIDs. Waivers are where CMS, the federal government, and states partner to allow the state's opportunity to test new or existing ways to deliver and pay for health care services. Basically, four types of waivers. To be 1915As, 1915Bs, 1915Cs, and 1115s. Our division are the 1915C, Home and Community-Based Waiver, and those are the ones that we will be talking about today. 1915C, Home and Community-Based Waiver, we commonly refer to Home and Community-Based as HCBS, so I will use that term throughout this presentation. What the 1915C HCBS waivers do is they allow states to deliver long-term care services in home and community settings rather than your institutional settings like your nursing homes or your ICFIDs. CMS codified these settings requirements, 42 CF, which is Code of Federal Regulations, in 440.301, which I know that's a lot of numbers and letters for you, but they codified our requirements in 2014. They are requirements that have always been in place with the actual waiver documents, which we'll get through here in a little bit. Another one to be familiar with are SB 40 boards. Those are Senate Bill 40 boards. They were developed in 1969, and they allow counties to pass a tax on personal property to support services for individuals with developmental disabilities. Those tax dollars are generated or managed by 9-member public boards in the counties. The Senate Bill 40 board language when we talk about our partnership for Hope Waiver, and that's where we partner with the Senate Bill 40 boards to provide services, and we'll get into that here in a little bit. A history on the waivers and Medicaid. Medicaid and Medicare were signed into law by President Lyndon Johnson in 1965. Tidbit of trivia here: former President Harry Truman received his first Medicare card, or received the first Medicare card. With the Medicaid's purpose is to furnish rehabilitation and other services to families and individuals attain or retain capability for independent or self-care. Basically, what we're wanting them to do is to be able to care for themselves, provide those services to help them become independent. What was signed into law in 1965, those services are known as state plan services. And so we'll talk a little bit about those. State services are typically available to anyone that is Medicaid eligible. And then on top of those state plan services, we will have our waiver services. So where waivers come from? Remember that Medicaid was signed into law in 1965. Well, in 1981, the Reconciliation Act was added as a section to the Social Security Act, and section was 1915C. And in that section, the Act described and authorized state Medicaid agencies to apply for home and community-based waivers. So again, typically state plan services are available to all Medicaid eligibles. With this Act, a new section, we can apply waivers to develop specific arrangements with the federal government to use Medicaid funding for specialized services and a target population instead of all waiver eligibles. So what this section means is that people no longer had to live in institutions such as ICFIDs, maybe psychiatric hospitals. We can take that Medicaid funding out into the community and provide services. First waiver for people with developmental disabilities was implemented in 1988. And our funding for those waiver services, the state provides 36% through state general revenue dollars, while the federal government provides around 64% of the funding. That fluctuates from year to year depending on the federal match rate. Waiver that's slightly different. That waiver is the Partnership for Hope waiver. And the state general revenue, that's the state, our division partners with Senate Bill 40s to provide share. So instead of the 36% from state, 18% is provided by the 40 boards, and approximately 18% is provided by the state. And the federal government still provides around the 64%. So it is a true collaboration between counties and the state. Okay. Into the details of a 1915C waiver. Earlier, we said that Medicaid covered services to the Medicaid population are called state plan services. Typically, services are available to all Medicaid eligibles. Well, the waivers allow states to develop an arrangement with the government to use Medicaid funding, again, for the specialized or targeted services to a target population instead of all Medicaid eligibles. So our waivers are targeted to those individuals that have otherwise been served in an ICFID, an institutional setting. And with CMS requires state line certain parameters. For example, how people will we serve in the waiver, what services are we going to cover, and how much will be spent on each service in the waiver. To define those parameters, states are also required to be cost neutral. And that means that the average cost per person in the waiver not exceed the average cost per person in an ICFID or institutional setting. So, in terms, we cannot spend more under the waiver than what we would have spent without the waiver. Calculating that cost neutrality, CMS has a specific formula that we have to use, and it is identified in their federal regulations, and I have that noted here in the presentation. Of course, we like to use some fancy terminology. D plus D prime is less than or equal to G plus G prime. So, foreign language waiver math, let's break that down for you. D, that is the estimated average cost for Medicaid waiver services. So whatever services you've identified in your application, that is the cost per person for the services. CMS has the prime, which is the D prime, That is estimated average cost for their state plan services. So your side is what does it cost per person to be in the waiver and their cost of state plan services. You add two together and less than the cost of an individual living ICF ID and their state plan services. So as you can, not just the waiver costs that are compared to the institution cost, it also includes the state plan costs on both sides. The waiver services provide impact the acuity of individuals and their cost of acute care, just as on the state plan side, services and their acuity and their acute care. So again, complicated, but we like to call this waiver math. But in that the cost of providing waiver services is not costing more than if an individual would have lived in an institution. Defined in the waiver is the population. So 1915C home waivers, the eligible population is defined as being eligible for Missouri of developmental disabilities, Medicaid eligible as determined by Missouri's Family Support Division. You have to have an evaluation of need for ICF ID level of care. And what that means is that you have to meet the federal definition of adult disabilities, which is 3 substantial functional limitations. You have to active habilitation need. There has to be a reasonable indication that you would have otherwise needed an ICF ID service unless you were provided the home and community-based waiver service. And care has to be determined initially and at least every 365 days from the initial date, because we want to see that you continually need that level of care. Okay, so we get into a little more detail, and I'm not going to read exactly the slides to you. We'll kind of walk through them. But within each waiver application, all states are required to have and describe their operational and administrative functions. These functions are performed by the single state Medicaid agency, which in Missouri's case, that is Department of Social Services, MoHealthNet Division. As in our division would be the operational agency. So we're going to quickly walk through several of these functions. Participant waiver enrollment. This function is the process of entering a waiver, which includes Medicaid eligibility, waiver eligibility, and your various intake activities. Waiver against approved limits. This is a process of making sure that we stay within the parameter that we talked about earlier of a limited number of people that we're serving in the particular waiver. This function also includes managing a wait list if we've waiver capacity. The next one, expenditures managed against approved levels. This funds the process of monitoring costs so that this remains cost neutral and within the parameters of the total estimated waiver cost. Remember that the waiver per person cost must be less than the per person cost of an individual in an ICF ID institution. This function is making sure that we stay within that limit. The level evaluation. This is a process of assessing individuals' continual need for waiver services. Only individuals needing waiver services should be in the waiver. We have participant service plans. This is the process of reviewing the service plans prior to the service plan implementation. This does not allow in this section for us to go back and retrospectively review the service plans to determine what was appropriate for a waiver participant's needs. Of waiver services. This is the process of reviewing the necessity of services before the division actually authorizes and has those services delivered. So services being requested actually meet the needs of the individual. function is a process to ensure services have been authorized in conformance with the requirements and utilization is within the waiver limits. It's important to note that this monitors that individuals are receiving services that are authorized for. Enrollment. This function refers to ensuring that providers are qualified through the enrollment process. Here in the division, we have kind of a two-step enrollment process. You have to enroll with the providers have to enroll with our division, and then the next step would be with Missouri Medicaid Audit and Compliance Unit with their provider enrollment to be a Medicaid provider. By CMS to have Medicaid provider agreements. So again, 1902A27, that is the Social Security Act. And then the federal regulation, they require that there must be an agreement between the Medicaid agency and each provider that furnishes services under the waiver. We also have an establishment of a statewide rate methodology. This function is having uniform and consistent policies across the state for rate determination. We require rules, policies, procedures, and information developed governing the waiver program. Is the development of all of our rules and our policies and procedures, and the single state Medicaid agency has ultimate authority over all of our rules, policies, and procedures to implement the waiver. We're also to have quality assurance and quality improvement activities. This function refers to the activities related to the discovery and remediation activities conducted for the waiver. We also look at any mechanisms for overall system improvements. So waiver services and state plan services, CMS also requires that state plan services are accessed prior to using any Medicaid waiver services. So the examples we have listed out here would be doctor's office visits, durable equipment, per care, pharmacy, hospital, home health, and therapies. So we have to use the state plan services before we utilize waiver services. Category of ensuring that we're following state services prior to waiver services. This is and periodic screening, diagnostic, and treatment. We commonly refer to this as EPSDT. In 1967, Congress introduced EPSDT for children under the age of 21 enrolled in Medicaid. This is not a program, this is a federal requirement. So I think oftentimes we receive questions about how to enroll in EPSDT. There is no enrollment for EPSDT. In EPSDT, we actually have to follow that requirement. And that we provide comprehensive services, all Medicaid age-appropriate screening, preventive services, and treatment that are medically necessary for children at the age of 21. So that includes vision, screening, dental, hearing, anything else that would be identified as medically necessary, diagnostic services, and therapies. So oftentimes when you're trying to access waiver services for children under the age of 21, we work with MoHealthNet to ensure that you've accessed the state plan services first. So within waiver, there are core services. There's something that the states follow, and that's CMS's technical guide for waiver applications. Waivers are here to complement state plan services. They're not to replace state plan services. Each waiver service identifies as core services that you can have in your waivers. They must specify the scope and nature of the service, limits on amounts, frequency, and duration. Each must specify provider qualifications, providing the services, and under statutory, other services, extended plan services, or self-directed services. And we'll get into the details of those here in a few slides. CMS core definitions for many services. States use those CMS core definitions as the basis, but we can modify or supplement those core services to more precisely reflect our needs in our specific state. However, if we propose any alternatives, we must fully describe what is and what that service is, and we cannot leave that definition open-ended. And then specific requirements, a specific they use to review to make sure that all services are consistent with their waiver service policy, coverage policy. Okay, as mentioned earlier, there's 4 different types of services that we can provide: status, other services, extended state plan, and self-direction. So we'll quickly go through those. Statutory services are contained in the 1915C section of the Social Security Act, and those services are considered statutory as long as the state's definition aligns to that CMS service definition. You can use alternative titles. So, for example, personal care may be called attendant care or personal assistance, but it's meaning the same thing, and that service definition is the same. But the title can slightly vary. Services would be any services beyond that statutory service. So when you propose coverage of an additional service, CMS will review that to make sure that it is not duplicating another service, that it's not duplicating a state plan service, and then they'll also ensure that that service is actually necessary to avoid institutionalization. Extended services, remember we talked about state plan services, that's covered under Medicaid. Sometimes there are limits on state plan services. We can add to our waiver that would cover any needs beyond the limitations under state plan. Have self-directed services, and that's where the participant or the participant's representative can direct some or all of their waiver services. The state is expected to make supports available to the participant as necessary to facilitate that participant direction. So you'll see that we have the support broker, we have our contractor that will assist with processing payments to the providers that the individuals hire. So a little chart, and you're able to download the presentation. You can have this at your fingertips. These are the core 1915C waiver services that are available on CMS. These are not the services necessarily that we have in our waivers, but statutory services can have things like case management, home care services, adult day health, residential rehabilitation, employment services, respite. You can also provide mental health services. There's quite an extensive list. Others that states have added are accessibility adaptations, medical modifications, non-medical transportation, that's transportation to community activities, assistive technology, skilled nursing, assisted living, adult companion services, bereavement counseling, career planning, services out there that are available. Okay, let me get into a little bit of the CMS review process. It would be easy if we could just put the waivers together and just run with it. But of course, you know, we're running through the federal government. It's a partnership with them, and they're providing 60% of our funding for this. So one of the things that we want to make sure of is that we are avoiding institutionalization. Our waiver target population, our targeted services are still in line with the goal and the mission, the 1915C section of the Social Security Act. So CMS looks at our waivers and for review for approval. They make sure that each service is defined separately, that we're not duplicating any coverage under state plan, and that EPSDT coverage. We receive that question a lot. How are you not duplicating the EPSDT requirement? When they look, they want to make sure that we're clearly delineating the purpose and the scope of the service, that spanning multiple unrelated services. They may be similar. Sometimes there's a combination, but we're not being repetitive. The services are supporting each other. When the scope of the service may potentially overlap the scope of another service, we have to ensure that there's mechanisms to prevent duplicate billing. Looks at non-statutory services to make sure that they are necessary to avoid institutionalization, and they address the functional impairments that if left unaddressed, that it would prevent the person from engaging in community activities. So again, all about preventing institutionalization and keeping people in the community and homes. Any defined duration, frequency, they have to be consistent with assuring the health and welfare of our target population. Have to be specified for each service, and they look to ensure that they're appropriate to the nature and the type of service. The patients that they look at would be training, experience, education, and they want to ensure that they are sufficient that the waiver participants will receive services in a safe and effective manner. Also ensure that provider qualifications do not include requirements that would unnecessarily restrict the number of providers and restriction of the provision of services. So the thing that CMS looks at is our rate determination. Waiver rates can be determined in a variety of ways, and frequently the methods that are employed vary by type of service. So you may have some services that are per diem, you may have some services that are on a weekly unit, maybe a per job unit. The main thing that CMS looks at is that all rate determination methods must be consistent with Section 2 of the Social Security Act, which is that payments are consistent with efficiency, economy, and quality of care, and sufficient enough to enlist enough providers. It should have monitoring processes to ensure that these requirements are met. And this isn't only for the Medicaid waivers. This is for all of Medicaid when it comes to the payment being consistent with the economy and quality of care. So we'll kind of a few different types of rate possibilities here. Rates may be prospective, or they could be retrospective, which if they're retrospective, they could have cost settlement, they can have interim rates. Rates may be established by maintaining a fee-for-service schedule, which is what we do here in Missouri with our waivers. Incorporate difficulty of care factors, so taking into account acuity levels to support those with differing support needs. Rates may also include geographic adjustment factors, so this would be your urban versus your rural to address different parts of the state. And then if you have participant direction services, identify whether that rate determination is used in a differing way, then you need to describe that. Ours are established in the same manner as our non-self-directed portions. So as all of those state laws, regulations, policies are cited and it's described carefully to MES, then they will do that appropriately. Okay, reviews our rates. They are the rate setting method that was used for each waiver service. It's not uniform for every provider of a waiver service, and waiver describes the basis for the variation. So if you are varying a little bit, you have to describe why your variance is there. It specifies the entity or entities responsible for the rate determination and how the oversight of the rate determination process is conducted. So is it the Division of Developmental Disabilities that determines the rate? Is it the Mo Health Net Division that determines the rate? That's to be described in the waiver application. They look to see that the Medicaid agency solicits public comments on rate determination methods, and then to see how the Medicaid agency solicits public comments rate determination methods. So are we comments throughout the year? Do we go out for our public comment whenever we our waiver renewal? They look for that detail. So we've talked about different requirements, and we have some more. For assurances, all of us, we have specific assurances that are required by CMS. I outline those in the waiver application, and oftentimes these are where performance measures will come in. So if you're a provider out there listening and we're running on you, it's because we're trying to ensure to CMS that we are meeting all of these components as well. So the state is expected to have, at the minimum, systems in place to measure, improve its performance in meeting their waiver assurances. And so we'll go through those here fairly quickly. Address important dimensions of the waiver quality. So we want to make sure that the service plans are meeting the individual's needs, that we have effective systems in place to monitor participant health and welfare. Applications are contingent upon meeting these performance measures. So CMS reviews on an annual basis at a minimum and report those through what we call a 372 report to CMS. That's mandatory reporting where they are checking all of our performance measures. And if there are areas where we are below 86%, we have to come up with to tell them how we're addressing those, because we do want to ensure the health and welfare of all of our participants. And yes, there is also the Office of Inspector General that may audit our waivers retrospectively. So here's the waiver assurances that we have to meet: level of care, service plan, health and welfare, accountability, and then administrative authority. Level of care. Level is that evaluation we talked about earlier that's provided to all applicants, and we on an annual basis to ensure that they're still appropriately needing waiver, and we're figuring what base level of care that they're needing. Is the service plans. This is a whole process where we develop an individual service plan. It includes the individual, the parent, the guardian, anyone that the individual receiving waiver services wants to have in the planning team meeting, your support coordinator, providers, natural supports. And this is something you're updating it as often individual needs. At a minimum, it's done on an annual basis. So it goes through and it addresses all their assessed needs, including any of their health and safety risk factors. The state has to monitor the service plan development to make sure that it's in accordance with the policies and procedures. We have that it's being changed when it's warranted by participants' needs. It has to be changed and revised at least annually, or updated and revised at least annually. We'll have to ensure that the services in the service plan are done with the limitations of the waiver definition. Participants, the service plan also has to ensure that participants are afforded choice, that they want a waiver service and not to an ICFID or a nursing home, and that they have choice among services and among providers. Is our provider qualifications. For provider qualifications, go through licensure or certification, either from Department of Mental Health or from a professional accreditation organization. We want to have that professional license. So your counseling, your therapies, they're required to have that professional license. We will ensure that providers are completing appropriate training determined by the department or the individual's planning team. We have to guarantee that there's appropriate supervision of staff. And it cannot be an individual, the provider cannot be an individual spouse, the parent if it's a minor child, or a legal guardian. Assurances are health and welfare, financial accountability, and administrative authority. The welfare, that's ensuring that on an ongoing basis, we're identifying and addressing of individuals, abuse, neglect, exploitation, and we're meeting again their health and their needs that they outlined in their plan. We want to make sure that we have to make sure that we have adequate standards for all types of providers. Accountability: the state has to have financial oversight to ensure assure that all the Medicaid claims are coded and paid in accordance with the reimbursement methodology, improved waiver application. Authority, our single state Medicaid agency, again, that's Department of Social Services, Health Net Division, they have the ultimate authority and responsibility over the waiver. Then of DD, we're the operating agency, and so we have Health Net come in and review. They have oversight of our performance of all the waiver functions. And that functions that those Senate Bill boards that we talked about, they have over those and all the contracted entities. Here is a list of resources that we have on our website. Find all of our guidelines on our website, our provider manuals, and there is a link to the federal programs page. So please feel free to dig through those and learn a little bit more about what the specifics are in our programs. And I want one for joining us today. And if you have any questions, again, please feel free to put those in, and we'll get those out to you, responses out to you as soon as possible.